We'll have the honor again to have our speaker, Dr. Professor Homer Yang. The topic will be valvular heart disease in pregnancy.
The housekeeping is important. Thank you. That was an excellent review by Dr. Noella Lucas. I'm going to carry on and talk about the maternal valvular diseases. The objectives is for me to review some of the physiological changes that the previous speaker touched on already a little bit, and understand the data that we have, which is actually quite unfortunate, not as robust as we would like them to be, and talk about some of the principles of management. So, the previous speaker already alluded a little bit to the changes in both the hemodynamics and some of the physiological changes during pregnancy. So what you see in front of you on the slide is talking the top line, the blue line is the cardiac output. So the x-axis is obviously the gestational weeks, and you see an increase easily from 35 to 40% during the gestation of cardiac output. At the same time, you see the mean arterial pressure initially dips a little bit, and then it sort of maintains back to normal. More importantly, you see the systemic vascular resistance just drops right down during the whole gestation period. This has been well studied, so it's useful for us to see that as what we would use as a standard to gauge as the normal pregnancy. The total blood volume also goes up. The plasma volume goes up. The red cell volume does go up, as you can see in the bottom green line during the gestation, but it doesn't go up as much. So that's why you see some of the hemoglobin dropping during the pregnancy, and the anemia starts to manifest itself. We also know that there are valvular regurgitation, which is normal in normal pregnancy. This is one study. There are several studies out there. You can look them up yourself on PubMed or Google search nowadays. There are 5 periods that this study's looked at, between 8 to 14 weeks, between 20 to 24 weeks, between 30 and 34 weeks, 36 to 40 weeks, and then 3 to 6 weeks postpartum. And what you see here is the 5 time periods, T1, T2, T3, T4, T5, and you also see the percentage of patients with regurgitation, the valvular regurgitation, and you see that the black bars are mitral valve regurgitation, the gray bars are tricuspid, thank you. My glasses not quite reading it. And then you see the pulmonic, and so this is normal that you would see during pregnancy. So we have to bear that in mind when we are managing patients with valvular disease. There are a lot of case series out there, and these are a series of cases, an individual center or a group of centers coming together, and then they do a case cohort studies matching the cases to controls, and then looking at outcomes and management principles. Very few actual large database out there, and the European Registry on Pregnancy and Heart Disease is one that is out there, short form ROPAC. And they looked at congenital heart, they looked at all the registry of cardiac diseases during pregnancy, and congenital heart disease certainly comes up the highest, and then the valvular heart disease, cardiomyopathy, ischemic heart disease. However, if you actually look at the distinction or the difference between developed countries versus developing countries, the proportion flips. So in countries such as OECD countries, the incidence of rheumatic heart disease has dropped significantly over the last decades. But in many of the other countries, rheumatic heart disease remains very high. I don't know the statistics in Kuwait, so I don't know where Kuwait stands. But one of the challenges we have is we don't have good databases worldwide to look at how the disease process is changing in different regions. We do know that rheumatic heart disease remains very high, and it's the main cause of valvular heart disease during pregnancy outside of OECD countries. I'm not going to talk about congenital heart disease today, because in 20 minutes there's only so much we can touch on. But this is just to show you that in congenital heart disease, some of the complications are a little bit different from rheumatic heart disease. And there are a number of bars, so it could be quite difficult to discern. But if you look towards your right, you will see the Eisenmenger disease or syndrome. And from there, you actually have cardiovascular complications, which includes MI, CVA, and mortality. So what you actually are looking at from Eisenmenger's, from congenital heart disease, these are patients born with congenital heart disease. Because of the improvement in management and various corrective surgeries, these patients grow older. Now they become pregnant, and they come with cardiac problems because of their congenital heart disease, corrected or otherwise. And Eisenmenger being one of the results of that, and they have complications, and their complications are somewhat different from rheumatic heart disease. Heart failure remains one of the most common complications from both rheumatic heart disease, valvular heart disease during pregnancy, and in congenital heart disease. And you can see that there are actually kind of three periods. X-axis is, of course, the gestation weeks, and the y-axis is the incidence. And between 25 to 30 weeks, you see the peak sort of right in the middle of the graph. That's one peak. And there's the blue bar, that's during the time of delivery. And we have the turquoise bar, which is in the postpartum period. So there are three periods that we actually see patients going into heart failure. And most of that is because the increased preload and heart rate, and that leads to the heart failure. And in the ROPAC data, median time is 31 weeks in all groups combined, but in mitral stenosis, the incidence is about 31%, but it peaks at 25 weeks for mitral stenosis. Maternal mortality, 4.8% in patients who develop congestive heart failure, and 0.5% without. So it is a very distinguishing feature if somebody starts to develop congestive heart failure. The complications from valvular heart disease, definitely you have congestive heart failure, you have arrhythmia. Most of the arrhythmia is atrial fibrillation. And because of the rheumatic valvular disease, the patients usually need the atrial kick. And if they go into atrial fibrillation, things actually really get much worse. There are fetal complications. Most common is the premature labor, but there is IUGR, and there is mortality. Mortality is about 1.7% in the ROPAC data. 60% or so of those, they actually couldn't determine the cause. And then 21% clearly due to maternal condition. So it's usually poor cardiac output, congestive heart failure, oxygen desaturation. The general principles really comes down to if the patient has mild, severe, or moderate mitral stenosis, valvular heart disease. And certainly in most cases, and for sure in moderate and severe cases, it has to be a multidisciplinary team. And obstetrician cardiologist and anesthesiologist or anesthetist need to be involved early on so that everybody is on the same page. There certainly is an argument to be made if it's moderate and especially severe, and some of the criteria are being outlined below. If we have a patient who is pregnant, there may be a need to discuss whether a termination is a wiser course. And some of those conditions will be already, the patient has had prior cardiac event or arrhythmia, New York Heart Association 2 or greater than 2, so 3 or greater, or already have cyanosis, central cyanosis. Ejection fraction is less than 40%, pulmonary hypertension, severe aortic stenosis or severe mitral stenosis, and severe AI or mitral regurg, and their function capacity at the New York Heart Association 3 or 4. So you have somebody like that, early on in the pregnancy, you know things are going to get worse, and there's a big question is whether we should even try to carry on with the pregnancy. If the decision is to carry on with the pregnancy, the general principle is to avoid cardiac surgery if at all possible. And this is in the case where you have to go back in and actually either fix the valve, repair the valve, do whatever. And most of that is because the risk to the fetus, because you've made the decision to save the baby, then if you go in before the second trimester, very, very high teratogenicity as well as abortion rate. If it is a stenotic valve, balloon valvulotomy is always possible and should be thought about if things start to go wrong. If a prosthetic valve is present, and this is in case someone who's already had previous corrective surgery, then thrombosis or hematology need to be involved because your anti-thrombotic agents need to be considered and followed up. And rate control with beta blockers has to be considered early on as well. During labor, this is more or less, again, alluded to by the previous speaker, that we see the red line, which is what happens to the cardiac output during contractions. And even between contractions, we see that the the cardiac output rather, starts to go up. And you can see on the x-axis, time 0 is the time of delivery. And you can see at that point, the cardiac output really goes up. So if we have someone who's already on the verge of heart failure or decompensation, this is the real stress test that's going to come. So we have to anticipate that. During the labor, if in the case of a moderate or severe valvular disease, say mitral stenosis being the most common one, really there should be very close hemodynamic monitoring. I think one of the things that I was not able to find a lot of information on is echocardiography. Definitely that's been the new tool we have in our armamentarium, and publications surrounding echocardiography and the time of labor has been somewhat paused. Nevertheless, we used it to guide our management when we had these cases, and it really has changed our management principles. And in most review papers as well as textbooks, and certainly in our teaching, we would suggest that a vaginal delivery with some sort of epidural analgesia without pushing, because with the Valsalva we will change the preload afterload relationship, and that's probably going to precipitate some sort of either arrhythmia or worsening heart failure situation. That's has been the traditional recommendation. It's been given probably for decades now, and all I would say is don't be rigid. We really have to see case by case what the right decision is. I've already mentioned the at-risk period. It's towards the end of stage 2 labor and immediately postpartum. And I'm talking about like 20 minutes, within the 20 minutes of the postpartum period. And they are also at risk postpartum for up to 24 hours. I just want to illustrate a case, with a case, 31-year-old gravida 1 at term for delivery due to symptomatic rheumatic mitral valve stenosis and regurgitation, and she was already in heart failure. Now, the recommendation of doing the vaginal delivery and epidural would have worked probably, except she couldn't lie flat, and she was already in heart failure, and she was becoming increasingly symptomatic as the labor continued. The mitral stenosis previously was described moderate to severe. Unfortunately, she refused valvulotomy during the second trimester because of the potential radiation exposure. And she was still in normal sinus rhythm, which was a good thing. And so I would maybe ask how people would feel given this kind of scenario. How many people would go for vaginal delivery? Can I see a show of hands? With an epidural? So I see a few. And how about just go straight for C-section and not... Yeah, with the epidural. And many are not quite sure.
Combine spinal epidural with cesarean section.
For those who didn't hear, the combined spinal epidural with combined spinal epidural for cesarean section was the suggestion up here. So after much discussion between the patient, the anesthetist, and the obstetrician, now I have to give the context. We've managed a few of these cases, and one of the first cases, which is not this case, in fact, we had to put the patient to sleep because the patient could not even sitting up, she was short of breath. She was severe mitral stenosis in pulmonary edema. So we had to put her to sleep. When the patient was induced, she immediately went into rapid atrial fib, and we actually asked the obstetrician to do the cardioversion, who promptly decompensated in front of us. So we had to do the cardioversion ourselves. And we got the patient back, and at the end of the case, patient did fine, baby did fine. So the obstetrician at this point actually really trust us, because we've already had a prior history of successfully managing these cases. So after much discussion, we actually elected to, it wasn't my case, so I want to be clear, and we elected to do cesarean section under general in this case. Yeah. So what ended up happening was with the general, we were able to monitor the cardiac function with a TEE all through the case. That was one of the advantages of the general. Can I have video 3, please? So this is the mitral valve. You can see the left ventricle towards the bottom and the left atrium towards the top. And you can see this patient does have mitral stenosis with the turbulence coming into the left ventricle and a fairly significant mitral regurgitation going back into the left atrium. Can I have video 4? And this is after delivery, and you can see, in fact, there's less of a mitral regurgitation, and it may be harder for you to see, but the turbulence for the mitral stenosis is actually less as well. Thank you. If I can have the slides, yeah. And of course, we also did the measurements. So this is before delivery. So after the induction of general anesthesia with the TEE, we did the measurement, and at that point, the transvalvular flow is about 240, 300 there. And so we can see that it is a stenotic valve. For those of you familiar with transmitral valve calculation. And we also did a prepartum left ventricular end diastolic volume calculation, and ejection fraction at that time was 43% after the induction of general anesthesia. LVEDB was 90 mils, which was pretty good. And this is the postpartum, and you can see the jet actually has increased. So we were witnessing an improved flow after delivery across the valve. And the ejection fraction actually went up. Now we anticipate it to go up, but it actually did go up. And the end diastolic volume was reduced because the ventricle was able to empty better. So we were actually pleasantly surprised, but this is not the first time we've seen it. And we are now actually trying to collect a series of cases, because what we're seeing now is, in spite of what we know, this is well measured, during the time of delivery, we are seeing improvement of mitral stenosis flow pattern across the left ventricle and the left atrium and the left ventricle just at the time of the delivery and after the delivery. This is in C-section. Now, we were kind of forced into a corner because the patient was short of breath, couldn't lie flat, and so we had to elect to go with the C-section. And you can see in this graph, this was from previous studies, looking at what happens to the stroke index and heart rate. You can see the panel as we're coming down, and you can probably read it better than mine because my glasses are not actually focusing it that well. Mean arterial pressure, the cardiac index rather, the third panel, mean arterial pressure, and the systemic vascular resistance index. So what you're seeing is we see the rise in the cardiac index, we see the rise in the stroke index, and then we see the drop in the SVRI. That is well studied in normal pregnancy, normal cesarean section delivery, but when we actually apply this graph to someone who has severe mitral stenosis, what we are actually finding that with the cesarean section, the flow pattern improved, whether it's because of the drop in the volume, whether it was a drop in the SVRI. We haven't quite all figured it out, but what we are suggesting to you is, one, don't be rigid, and two, monitoring the echo may well be bringing us a new set of understanding around the time of this management. So, in summary, most of the OECD countries right now, the cause is congenital heart disease for patients coming with heart disease during pregnancy. But most of the non-OECD countries, the cause is rheumatic heart disease, and mitral stenosis being the most common. Now, for the sake of time, I did not go into all the other causes of cardiac diseases. We've had to manage Marfan syndrome. We've had to manage, because then we have the aortic insufficiency, we've had to manage coarctation. Those we're not, I'm not touching it because of the time. And we touched on the risk period is 27 to 28 weeks when patients go into heart failure, and immediately postpartum. And the complications that we see during those times would be the heart failure and or atrial fibrillation. And team care is crucial. So if you have such a case, don't try to manage yourself and think that this is easy for yourself. And I would also put it out there, make sure within your department the people who are experienced in dealing with this sort of cases be involved. You can disseminate the expertise, but don't try and rediscover the wheel on your own. Hemodynamic monitoring, epidural and vaginal delivery, those are the I guess the safest recommendation out there. There are circumstances that we get cornered, as this case that I present to you, a patient who cannot lie flat and we knew could not labor any further, and we risk running into problems, so we actually went for C-section. And in that case, we did the general anesthetic with a C-section. I would also say very likely with the epidural it would be just as well, but it would be a bit more challenging to monitor the echo unless you're well versed with transthoracic echo. And the C-section changes in the SVRI and the blood loss, at this point we think may be advantageous, but it's too early for me to really give you a strong recommendation here. And overall the data is still very, very weak. There are good registries out there, and we're starting to understand more the incidence and the prevalence and the incidence of complications. And the challenge has been, by and large, you're looking at significantly less than 1% of our delivery volume. That's why we continue to try and figure out what is the right thing to do. Thank you.